NPTE Study Cast.
All right, here we go. The next episode of the NPTE Study Cast, we're talking about peripheral nerve entrapment of the upper extremity. I guess this could be presented in a bunch of different ways.
Yeah, I can. So I just kind of wanted to do a little overview of it just to give you some teasers of really what you need to know to get a lot of these questions right. So what is it? Can be a couple of different things. So it could be that it's tension on the nerves. So they're getting stuck somewhere, right? Because remember, they're going all the way from the cervical spine all the way down to the fingers. So the nerve could be unable to move. It could be an entrapment, or basically it could have stretch type of an injury that occurred, like a traumatic
Nerves
injury.
hate to be stretched.
They hate it, yes.
Signs and symptoms.
Symptoms that your patient would be telling you about when you were interviewing them. Heaviness is one of them. Numbness and tingling. They could also have pain. They could have frank sensory loss. And if it's been longstanding, they can also have motor loss. And you just have to be aware that patients may describe numbness and tingling in different ways to you.
Electric. Right. Pins and needles.
Yeah, those
Heavy.
Different types of things. But anything that you remember as a student as being associated with nerve pain, that should be one of the things that they're going to be describing to you. If we think about the differential diagnosis, big thing with the nerves is you have to make sure that it's actually really being entrapped down from the cervical spine. So that's the big
Peripheral
thing.
versus
Correct.
central.
Peripheral versus central. So you really want to start thinking about looking at dermatomes versus looking at peripheral nerve patterning. One of the big things that you can do with diagnosis is getting nerve conduction velocity studies, or EMG, but you're not going to have that when you take the NPTE. But there's a lot that you can learn from the anatomy and just from the different special tests that you do that can really help you determine if it's a peripheral entrapment versus it's more of a central issue, like it's a disc pathology or a stenosis, and that's encroaching upon your nerve root.
Anatomy.
Let's talk about the anatomy.
Okay,
So
anatomy.
when we talk about the upper extremity, we're really going to focus on, even though there are more than what I have listed, there's 3 big nerves that can get entrapped, but I know that there's more than just 3.
But the test goes
for the chest,
go for the most common.
So we have the median nerve, we have the ulnar nerve, and we have the radial nerve. So median nerve, just to remind everyone, it's C5 through T1, but it's mostly C6. Ulnar nerve is C8, T1. Radial nerve is C5 through T1, but it's also mostly associated with C7. Okay. So median nerve, when you're thinking about what are the 2 big syndromes of peripheral nerve entrapment, I'm thinking pronator teres syndrome, or I'm thinking carpal tunnel syndrome. Those are my 2 big differential diagnoses. So if it's a pronator teres issue, pronator teres is going to feel sort of like a heaviness kind of in the forearm. And remember, we're talking about anatomical position. So it's going to be the thumb side of the forearm, which is also considered to be the lateral forearm. They would have all of the same symptoms that somebody with carpal tunnel might have, except for they're also going to have weakness in their forearm flexors. Whereas if you just have carpal tunnel syndrome, you're going to have finger flexors. And they would probably have weakness in pronation, right? If we had carpal tunnel syndrome, we wouldn't have weakness in pronation.
So there's your differential diagnosis there.
Yep. So ulnar nerve, so again, that's C8T1 coming off the medial cord. So that can get trapped in a couple of different places, 2 of which are right near each other. It can get trapped in between, there's 2 heads to the flexor carpi ulnaris. It can get trapped in there. It can also get trapped in the cubital tunnel, which there's a little ligament called Osborne's ligament that goes across right where your ulnar nerve is, at that medial epicondyle. And then it can get trapped way down in the hand, on the pinky side of the hand, or the medial side of the hand, and it's called Guyon's canal. But anatomically, there's a ligament that goes from the pisiform to the hamate. So it's the pisohamate ligament. So same kind of thing when we talked about with the median nerve, is if you have your ulnar nerve trapped up near your elbow in that cubital tunnel, you're going to have issues locally. So you might have paresthesias or pain in your medial forearm, and you'll have the hand weakness because it's going to have decreased signaling all the way down. But if you just have the Guyon's canal entrapment, you're going to have that, just the issues that would go from that pisohamate ligament down to the finger. So your medial forearm would be spared, and it would be fine. And the last one that we have would be radial nerve, so C5 through T1. So that can get trapped in between the heads of the triceps. That's pretty rare, but it can get trapped there. And it can get trapped inside of the supinator. You can also get trapped inside the radial tunnel, but that would just be your PIN, which is your posterior interosseous nerve. Sometimes they may throw you a question where the superficial radial gets entrapped, and that's a tight cast, so that's on the dorsal side of your wrist. And if you have a short arm cast, sometimes they'll throw that at you because it only gets the superficial radial, which is sensory only, so you wouldn't have any motor loss. You just have sensory loss. But radial nerve entrapment's pretty profound because you lose all your extensors. So whereas on the flexor side of the arm, you have median and ulnar. So yeah, it's pretty bad to lose the ability to move your thenar eminence, so your thumb, but you can flex part of your other hand because you still have your ulnar nerve. But when you knock out your radial nerve, you lose extension's gone. And that's a movement that we need in life in order to have a lot of stability. In terms of different special tests that you can do to, we talked about anatomically how you could differentially diagnose. If your median nerve is a problem, if it's carpal tunnel specifically, you can do the Tinel sign. You can tap on the median nerve. You can do the Tinel sign anywhere. I mean, a lot of students learn it just at the carpal tunnel, but right. you can hit anybody anywhere where the nerve is. Ulnar nerve.
Positive sign
pain. Yep. And you can do Phalen's test. So essentially that's putting somebody into extreme amounts of wrist flexion. So it's closing off that carpal tunnel. So that median nerve is getting squished. Also, if you look at the hand and you see that the thenar eminence is wasted, we call that simian hand. So if there's a flattening on the thumb side of the hand, that
does take a while to atrophy.
It does, yeah, because that's motor loss, right? You would have people most likely telling you that they have sensory symptoms before that. If we look at the ulnar nerve, you don't have as many, because your hypothenar eminence is not as big, so you do get some muscle wasting if it's trapped at that pisohamate ligament, but it's not as pronounced as if you were to have your thenar eminence gone. Your ulnar nerve in your hand supplies your interossei and your lumbricals, so you would get what's called a static claw. So you would actually have your fourth and fifth digit would be flexed, and they would be flexed all the time.
Is that Bishop's hand?
Bishop's hand is the median nerve.
I always get that confused.
Actually. So that's a great question, though, because the test would have to tell you, if they give you a picture or they say you're looking at a patient who has a flexed fourth and fifth digit, they would have to tell you if it was at rest or you asked them to make a fist.
Got it.
So Bishop's hand is you physically said to your patient, make a fist, and they can't flex 1, 2, and 3, and that should make sense because those are all median nerve.
Gotcha.
I am remiss, I should back up for the people that may be not as good with their innervations as they used to be. So median nerve is going to do digits 1, 2, 3, lateral side of the fourth. Ulnar nerve is going to do medial side of the fourth and fifth. And then radial nerve is the entire back of the arm. If you know that, you can get a lot of these questions right. You can do your Tinel sign for your ulnar nerve if you want to tell where that's trapped. Radial nerve, biggest sign you're going to see is wrist drop. So we usually just do manual muscle testing for radial nerve. So if it was trapped in the triceps, you may have a little bit of triceps weakness, and then you'd have all your wrist extensors would be compromised. If it's trapped in the supinator, you may have your wrist extension might be weak, but it might not be absent, but you might have more weakness in supination. Those are some things we can do.
Treatment examples.
Now, in terms of treatment for these guys, so if it really is a peripheral nerve issue and it's not a disc or, some sort of stenosis in the spine, we can do a couple of different things. We can do nerve glides, right? So we want to try to get that nerve sort of moving better in between the muscles and the sheath that it has to travel through. It may be that we have to do patient education. So a lot of people that suffer with carpal tunnel syndrome, it's because they have very bad ergonomics at work. So a lot of people, it's the way that they actually type or how they have their computer set up or where they put their mouse, or a lot of people, it's actually the way they sleep. So they sleep with their, sort of in the fetal position with their hands and wrists in a lot of flexion. So up night splints work for some people, but really just talking about ergonomics, biomechanics with those people can help somewhat. And then manual therapy. So manual therapy to try to restore normal flexibility. So if you're thinking about if you have your median nerve trapped in between your pronator teres, if you have a really tight pronator teres, it may help them if you can use soft tissue mobilization to try to get that nerve to glide a little bit better because it's not so entrapped by that. Other treatments that your patients will get, surgery is a big one, especially for carpal tunnel syndrome. So what they'll do there is they just release that transverse carpal ligament. Only the median nerve is in the carpal tunnel. The ulnar nerve's not inside the carpal tunnel. Some people will also get corticosteroid shots. Those don't work great. So rehab is usually your best treatment for these entrapments.
Here's your example question.
All right, sample question. How are we going to see this in the NPTE?
All right, so they could tell it to you in two different ways. Upper limb tension tests. All right, so ULTT. Also, they are called LVs tests. So know both of those.
Okay.
Yeah, they have two different names.
There's a couple words that popped up on the NPTE that I've never seen before.
And that's not that uncommon. It really depends on what your program teaches you.
Right.
If it's a word that you really don't recognize, but you recognize all of the responses, then just go with, okay, that's the test that I think it is, and they're calling it by a different
It was just
name.
a different name.
Yeah, exactly.
Don't panic.
Yeah, you can get completely caught up in memorizing the names of all these different tests, and that's a complete waste of time, I think.
Just remember what it does.
Exactly, and
Set.
that's a great strategy, is look at the answers first, so don't get tripped up by the
All
question.
right, so what's our sample question?
All right, so our sample question is, you are a physical therapist and you have done an upper limb tension tests, and you put the patient in the position of shoulder depression, abduction, external rotation, supination, wrist extension, finger extension. What nerve entrapment would that test for?
Okay.
All right, so choice 1 is median. Choice 2 is ulnar. Choice 3 is radial. Choice 4, musculocutaneous. All right, so the correct answer is median nerve.
Let's talk about why that's the correct answer.
This is the description of upper limb tension test number 1, which is the test for median nerve. Most of it is if you think about median nerve, so you want to stretch it. That's what the point of an upper limb tension test is. So you want to go in the motion opposite to where this nerve would be going. Almost all these tests do shoulder depression and abduction because you're trying to bring the arm away from the body and stretch the brachial
Tension.
plexus. So that's common with all the tests. You also almost always put them into external rotation, same reason. But supination is a little bit different. Okay, and then you're putting them into wrist and finger extension. So the supination, if you think about median nerve, goes right through the pronator teres. If you put them into supination, that's going to stretch the median nerve. So, and then you have that excessive wrist and finger extension, and median nerve is part of the flexor compartment. That's why.
So right off the bat, you can throw out musculocutaneous and radial, and then it's between your ulnar and your median.
Yep. And because ulnar doesn't do anything with supination versus pronation, that's going to be your key for that one.
So we've narrowed it down.
Yep. Great. So that's upper extremity nerve entrapments.
That's it. That was easy.
NPTE Study Cast. Brewed by the PT Pintcast.